question number 11, all of you. A typical pedigree. Now you tell me, guys. Question 11. Tell me the answer. Based on the same funda. So we will apply the same funda today. Yeah. So the same funda we applied. All the generations are affected. All generations are affected. So this is dominant. Number 2, we found equally occurring in males and females. Number 3, we also found that father is also giving the disease to son also and to daughters also. So it is not X-linked. It is autosomal. Okay. Remember, dominant disorders, Mendel said, dominant disorders mostly present in heterozygous state. So Mendel said dominant disorders mostly present, so they are mostly like this, AAC. Dominant disorders mostly present in heterozygous state. Okay, they are mostly heterozygous. They don't need to be homozygous. They are mostly heterozygous. Okay. So all of you should know the examples of autosomal dominant, and the mnemonic is dominant VH3. Okay, myotonic dystrophy. So this is my mnemonic, dominant VH3. So myotonic dystrophy is autosomal dominant. Myotonic dystrophy. Osteogenesis imperfecta. They are heterozygous, Dr. Chakraborty. They are heterozygous. So they may give a normal allele to the daughter also. Okay. So not all daughters will be affected. Okay. They are heterozygous, na? So they are like this, Dr. Chakraborty, AAC. So if it's like this, see what will be the possibility, AA, 50%, na? So you can also have a normal child also here. Okay, Dr. Chakraborty. Osteogenesis imperfecta is autosomal dominant. Marfan syndrome. Okay. Intermittent porphyria. It is porphyria. Intermittent porphyria. Noonan syndrome. Achondroplasia. Neurofibromatosis. NF is neurofibromatosis. T stands for tuberous sclerosis. Remember another important autosomal dominant ENT syndrome called Treacher-Collins syndrome. Treacher-Collins syndrome is autosomal dominant. Von Willebrand disease is autosomal dominant. And 3H. Okay, and 3H. Huntington's chorea. Hypercholesterolemia. Hypercholesterolemia is autosomal dominant. They are all autosomal dominant on your screen. Hypercholesterolemia and hereditary spherocytosis. Hereditary spherocytosis is also autosomal dominant. Okay. Yes, Holt-Oram syndrome is also autosomal dominant. We just discussed. Let's take you to the next pedigree. So remember 3H, Huntington's chorea, hypercholesterolemia and hereditary spherocytosis. Let's take you to the next pedigree of the day. Question number 12. We have 20 clinicals today and here is question number 12. Now what do you see here? Guys, what do you see here? Question number 12. Now the parents are carriers. So now, so I said whenever you see a pedigree, number one, you should look at whether the all generations are diseased or not. Now here all generations are not diseased. Here parents are carriers. So this becomes recessive. Now can anyone tell me who is a carrier here? Anyone in the class? Who is a carrier here? Male or female? Can you see this half black? Who is a carrier here? Both males and females are carriers. It becomes autosomal recessive. Both males and females are carriers. It becomes autosomal recessive. And I can make it like this, guys. Consanguineous marriage. These two were actually, cousins. The cousins fell in love. They got married. So consanguineous marriages, remember, consanguineous marriages precipitate autosomal recessive traits. Okay, consanguinity precipitates, male is a square, female is a circle. Okay, remember male is always a square, female is a circle. And whenever I say full dark, it means it is affected. Okay, whenever I say full dark, it is affected. So here both males and females are carriers. It is autosomal recessive. Consanguineous marriages precipitate autosomal recessive traits. Remember, a lot of metabolic disorders are autosomal recessive. For example, cystic fibrosis, congenital adrenal hyperplasia, Hurler syndrome is mucopolysaccharidosis type 1. Hurler syndrome is mucopolysaccharidosis type 1. Wilson's disease, alpha 1 antitrypsin deficiency, hemochromatosis. So these are mostly the metabolic disorders like hemochromatosis, alpha 1 antitrypsin deficiency. Yeah, you're right. Tay-Sachs. Gaucher's is very important. Gaucher's and Niemann-Pick's. Tay-Sachs, Gaucher's and Niemann-Pick's. Remember, Gaucher's is very important because Gaucher's was the first disease for which enzyme replacement therapy was successful. Yeah, sickle cell is also autosomal recessive, yes. So Gaucher's was the first disease for which enzyme replacement therapy was successful. Okay. Deficiency of enzyme beta glucocerebrosidase. Deficiency of enzyme beta glucocerebrosidase. Okay. So this enzyme is commercially available. Let's take you to the next pedigree. And I really want someone just asked me a question. I wanted to ask this question to her. Uh, I'm forgetting the name. Anyway, so tell me now. Again, look at the same funda. Parent is carrier or diseased? Anyone? Now, parent is carrier or diseased? Parent is carrier. So this becomes recessive. This becomes recessive because parent is a carrier. Now, is there a sex preference, all of you? Is there a sex preference? Is there a sex preference? Yes. Only poor boys are affected. Only poor boys are affected. Females are carriers. Females are carriers and poor boys are affected. X-linked recessive. Females are carriers because females are fortunate, they have two X chromosomes. So only one X is having the problem, XXC. Now poor boys, they have only one X chromosome. So those boys who get this abnormal X chromosome, they get diseased. So in X-linked recessive, females are carriers, poor boys are affected. For example, Duchenne's muscular dystrophy. Duchenne's muscular dystrophy. Becker's muscular dystrophy. Hemophilia A, hemophilia B. Wiskott-Eldridge syndrome. Chronic granulomatous disease. Chronic granulomatous disease. Lesch-Nyhan syndrome. Chronic granulomatous disease, Lesch-Nyhan syndrome. Yes, very important for our country. North India, G6PD deficiency is common in North India. And yes, mucopolysaccharidosis type 2, Hunter. Hunter is mucopolysaccharidosis type 2, X-linked recessive, Hunter. Color blindness is also X-linked recessive. Color blindness, Hunter, they're all X-linked recessive. Cool, all of you? Cool? Cool? So let's take you to the next inheritance. The next Mendelian pedigree of the day. And now on your screen is a Mendelian pedigree. Now tell me, what do you think? Let's go back to the same funda. All generations are affected. This is dominant. No doubt about this. This is dominant. Now, is there a sex preference, guys? Anyone? Question number 14. Is there a sex preference? Is there a sex preference? Yes, there is a sex preference, all of you. How? How did I say? Look at any affected male. He's giving the disease to all daughters. An affected male gives the disease to all daughters. So this is classic, all of you. Affected male gives the disease to all daughters, none of his sons, none of sons. Because a male gives which chromosome to his son, guys? A male gives which chromosome to his son? Y. Now the problem is on X. So the problem is on X. So an affected male gives the disease to all daughters, none of his sons. This is X-linked dominant. So all of you, whenever you are marking dominant in your exam, you have to look at this classic thing. Look at any affected male. Look at any affected male. Okay? Look at any affected male. Yeah, everyone is writing Y. Basically, I asked you, a male gives which chromosome to his sons? Y. So whenever you are marking this in your exam, all of you, look at an affected male. If he is giving the disease to all daughters, it is X-linked. In a single sentence, remember, if in X-linked dominant, there is no father to son transmission. There is no father to son transmission in X-linked dominant. Okay? Anirudh, I don't know what he's saying. Beta, listen to me carefully. Mendel said dominant disorders are heterozygous. So this female is heterozygous, Anirudh. She can give a normal female, have a daughter also. She can have an abnormal daughter also. Okay? So to identify, Anirudh Singh, listen to me carefully. You have to give me the answer to this question. So what is the trick? The trick is look at affected male. An affected male gives the disease to all daughters, none of his sons. There is no father to son transmission in X-linked dominant. Okay? So the trick to identify this, Anirudh, is this. Okay? So what are the examples? Rett syndrome, inconsentia pigmenti, Aicardi syndrome. Okay? And very commonly we see this in my hospital, X-linked dominant hypophosphatemic rickets. X-linked dominant hypophosphatemic rickets. Okay? Okay? So now all of you listen to me carefully. I have a question for you. My question to you is, these three syndromes are only girls. Rett's, inconsentia and Aicardi are only seen in girls. Why? Where are the boys, guys? Where are the boys? These three syndromes are only seen in girls. Where are the boys? They die. These three syndromes are lethal in male fetuses. So only females survive. So these three syndromes are lethal in male fetuses. So only females survive. Okay? So only females survive. So these three syndromes are only seen in females. Okay? Remember this. Let's go further. So we talked enough about the Mendel. Okay? We talked a lot about Mendel. Let's talk about something which is non-Mendelian. Okay? So let's take you to a very important syndrome. Okay, this is a syndrome. This may be dominant. You have to tell me what is this. Okay? This is a favorite syndrome of your examiners. So here is a child, all of you. a 4-month-old child with peripheral pulmonary stenosis. This is a 4-month-old child with peripheral pulmonary stenosis and he has jaundice, direct jaundice with butterfly vertebra. What will you think of? What will you think of in peripheral pulmonary stenosis? We'll talk about peripheral pulmonary stenosis today, and a baby with direct jaundice. And butterfly vertebra. Remember all of you, this is a favorite question of your examiners. This is an autosomal dominant disorder called AIIMS syndrome. AIIMS syndrome. What is AIIMS syndrome? It is basically paucity of the bile ducts. It is AIIMS syndrome, paucity of the bile ducts. So these children have less bile ducts in the liver. It is paucity of the bile ducts in the liver. AIIMS syndrome. Okay. Mutation in the gene called JAG1. Mutation in the gene called JAG1. Remember, favorite question of your examiners. The classic heart disease in AIIMS syndrome is peripheral pulmonary stenosis. These children have a triangular face and deep eyes. Remember, these children have a triangular face and deep eyes. Gehri aankhein. They have triangular face. So remember, your examiners, some of your examiners really like to ask about, I'm sorry, can you hear me? I hope it is not disconnected. Yeah. So AIIMS syndrome classically have deep eyes and triangular face. And they have peripheral pulmonary stenosis. Okay. Okay. So all of you should know that there are three very important syndromes in which you see peripheral pulmonary stenosis. Maybe tomorrow in neonatology also you will hear about this. Number one, today I told you about the AIIMS syndrome. Number two, an autosomal dominant. Number two, we just today talked about a micro deletion called Williams, in which there is a supravalvular aortic stenosis and hypercalcemia. Okay. Number three, okay, I will again rejoin, but let's write this, then I'll rejoin. Okay. Number three, remember, it is also seen in rubella. In rubella, PDA is the most common, but they can also have peripheral pulmonary stenosis and VSD. So in rubella, PDA is the most common. Okay. They can also have peripheral pulmonary stenosis. Okay. And VSD. So let's go further and let's take you to the next inheritance. Let's take you to the next inheritance. So all of you tell me now what is happening here. Tell me what is happening here, all of you. Dr. Sanjana, I said AIIMS syndrome has paucity of the bile ducts. They have less bile ducts on their liver biopsy. Okay. So all of you, let's tell me what's going on here. So all of you can see the only word here is ma. Maternal inheritance is mitochondrial. So on your screen you can see maternal inheritance, which is mitochondrial. So if I have to tell you in sentences, I will say all children of affected mother are affected. If we get all of our mitochondria from the mother. So all children of affected mother are affected. If mother is affected, all are affected. But none of affected father. But none of affected father. None of affected father. Okay? Mitochondrial. Mitochondrial. What are the examples of mitochondrial inheritance? Remember, MELAS is mitochondrial encephalopathy. MELAS is mitochondrial encephalopathy. Lactic acidosis and stroke and stroke-like episodes. Okay? MERRF, they have basically a myoclonic epilepsy or a mitochondrial epilepsy with ragged red fibers on the muscle biopsy. Ragged red fibers on the muscle biopsy. Leber's hereditary optic neuropathy is mitochondrial. Leber's hereditary optic neuropathy is mitochondrial. NARP syndrome. What is NARP? It's neuropathy, ataxia and retinitis pigmentosa. Neuropathy, ataxia and retinitis pigmentosa. Okay. Then another syndrome called Kearns-Sayre syndrome, Pearson syndrome. And let me tell you about the Leigh disease, LEIGH, in which an infant has refractory epilepsy. In Leigh disease, an infant has refractory epilepsy. Chronic progressive ophthalmoplegia is also mitochondrial. Chronic progressive ophthalmoplegia is also mitochondrial. Okay. Deafness because of aminoglycosides. Deafness especially which is related to aminoglycosides is also mitochondrial. Okay, cool. Cool. Deafness which is because of aminoglycosides. Okay. So remember, maternal inheritance is mitochondrial. Okay, these are the examples. Let's take you further to question number 17. Now tell me guys, what is happening in this question number 17? Question 17 is an infant with weakness, okay, irritability, and he has a mitochondrial defect in the pyruvate dehydrogenase defect. Okay, Leigh's disease, Sanjana, we'll just talk about that. Hold on. Dr. Vanya, not necessarily. So all of you, here is a child an infant with irritability, weakness, and defect in the mitochondrial pyruvate dehydrogenase deficiency. So remember, this is Leigh disease. Leigh. What is Leigh disease? Like the case describes here, an infant with unexplained irritability, weakness, and defect in the pyruvate dehydrogenase enzyme. Defect in the pyruvate dehydrogenase enzyme. Okay? Mitochondrial. Defect in the pyruvate dehydrogenase enzyme. This is mitochondrial. Okay? So just remember these three things about Leigh disease. An infant with unexplained irritability, weakness, and defective production of pyruvate dehydrogenase. It's basically a mitochondrial defect. So mitochondria में होते हैं ना, the pyruvate dehydrogenase pathway. So that is defective here. Okay, so let's take you to almost the last few defects of the day. So what I'll do is I'll start with question 19 first, and then I'll take you to question 18. Okay, I'll start with question 19 first, then I'll take you to question number 18. Question 19. All of you, here is a pedigree. It's a very interesting pedigree. Then I'll take you to question 19, then 18 and 20. They're all related. So here is a pedigree, all of you. Of course, this is autosomal dominant. So I have already told you the fundas. This is autosomal dominant. But my question to you is, okay, this is autosomal dominant. There's no doubt about this, okay? Male and females equally affected. But my question to you is, can you tell me what is happening here? Question 19 is autosomal dominant. Now, can you tell me which phenomena is happening here? This baby on your right side was born with hypotonia. This baby on your right side was born with hypotonia, was floppy at birth. Now his mother had a grip problem. Whenever she would hold someone's hand, she would not be able to release. So his mother has a grip problem. His grandmother had only cataract. So can you see a pattern here? What pattern can you see here? That this genetic disorder is becoming more severe with every successive generation. Can you see? With every successive generation? Okay? With every successive generation, disease is becoming more severe and is presenting early. So this is a classic pedigree, all of you, of myotonic dystrophy. Autosomal dominant myotonic dystrophy. Autosomal dominant myotonic dystrophy. With every successive generation, the disease is becoming more severe and is presenting early. Okay, and is presenting early. And what else can you see? With every successive generation, you can see the trinucleotide repeats are increasing. With every successive generation, the trinucleotide repeats are increasing. Can you see? This baby has 1200 repeats, mother has 500, grandmother had 120. So listen to me carefully. What is anticipation? With every successive generation, disease is becoming more severe and is presenting early. With every successive generation, the trinucleotide repeats are increasing with each successive generation. Okay. So now let's take you to question number, let's see. Yeah, let's take you to question number 20 first. All of you. Question number 20 and then I'll take you to question number 18. Question number 20, it's a boy who has difficulty in releasing the grip. Whenever he holds someone's hands, he's not able to release it. He has a problem in grip release. Grip release. His father had a cardiomyopathy. This boy has temporal wasting. The typical myotonic phase is temporal wasting. He has difficulty in plantar dorsiflexion. What is myotonia actually, guys? Myotonia means incomplete relaxation after a contraction. So myotonia is actually incomplete relaxation after a contraction. So myotonic dystrophy, can you see his father had 22 years problem. Now this boy has problem at 9 years. So with every successive generation, disease is becoming more severe. Okay. Remember, myotonic phase. What is a typical myotonic phase? Inverted V upper lip, and temporal muscles are lost. Temporal wasting. Temporal muscles are wasted. Temporal wasting. So this is a classic autosomal dominant myotonic dystrophy, which also exhibits anticipation because it is a defect of trinucleotide repeat disorder. It is a defect of trinucleotide repeats. It's a defect of trinucleotide repeat disorder. So this exhibits anticipation. So this exhibits anticipation. Okay. So this is a typical myotonia. Okay. And anticipation. Now with every generation, disease is presenting early. So let's take you to the last question of the day. Question number 18. It's a 12-year-old boy who has some behavioral problems. This 12-year-old boy has some behavioral problems. He has autism-like features. He has large ears, prominent jaw, and a large testis. So in which condition do you have some behavioral issues with a large face, large ears, prominent jaw, and macroorchidism? Large testis, large face, large ears, prominent jaw, and large testis. It's a disorder, an X-linked disorder. The multiple repeats of CGG on the X chromosome called Fragile X syndrome. It's a disease called Fragile X, multiple repeats of CGG on the XQ, multiple repeats of CGG on XQ. CGG repeats. So I'll show you a child with Fragile X, and all of you, this is a typical case of Fragile X. In this movie, actually, this boy, this is Amir Khan, by the way, those who don't know, he was again and again showing his prominent ears. He was showing his prominent ears. So he was trying to tell you that, guys, he is mentally retarded. He has large face, large ears, And if you look at the teaser of this movie, I don't know if you remember the teaser of this movie. In this teaser, he was trying to hide his testis by a radio. I'm sorry, I can't show you that photograph here. I can't do that. So he was telling you right from the teaser of the movie that he has Fragile X syndrome. Okay, this is a classic case of Fragile X on your screen. This is a real Fragile X. And can you see this just looks like Fragile X? A typical case, large face, large ears, prominent jaw and large testes. So remember, Fragile X is X-linked. Okay, it is X-linked. So it is severe in boys. Okay, now remember CGG repeats on the XQ 27.3 locus. CGG repeats on XQ 27.3 locus. It is the second commonest genetic mental retardation in boys. It is the second commonest genetic mental retardation in boys. More are the repeats, more is the problem. So boys with Fragile X are mentally retarded. They have large face, large ears, prominent jaw and large testes. Now females, I said it's X-linked. So in females, okay, in females, their IQ is normal. In females, IQ is normal. Okay, but they have mild problems. Premature ovarian failure. Premature ovarian failure. So they may have a premature ovarian failure. So they have premature menopause. Okay. So remember these females, their IQ is normal, but they have premature ovarian failure. Okay. So all of you, what we did today was we talked about what is the classic, integrated kind of teaching. In your exam, you will get, you may have a patient and they may ask you which pharyngeal pouch is problematic. You may have a patient, they may ask you which chromosomal defect is this. So don't worry guys, whatever teaching we do at DAMS is all integrated. So whether I talk about pediatrics, I'll in between, we'll keep on discussing which enzyme deficiencies are common in these children, whether it's an anatomy defect or an embryology defect. So I don't think there is anything to worry. The word to go is integrated teaching, and this is what we do. And if you have any doubts, guys, feel free to tag me on any of the social media platform. I'm on Instagram, Facebook. You can mail me if you have any doubts, and we'll keep on seeing you, and we'll keep on discussing various aspects of pediatrics in coming classes in the typical integrated way. Okay, so if you have any doubts, guys, feel free to tag me. Thank you and all the best.